topic on rare case series of Krausen syndrome in a family. Introduction. Krausen syndrome is an autosomal dominant disorder with complete penetrance and variable expressivity or can appear as a mutation. It is described by French neurosurgeon by name Octave Krausen in 1912 as it is a rare genetic disorder. It may be transmitted as an autosomal dominant genetic condition. It is caused by mutation in the fibroblast growth factor 2 genes. The disease is characterized by premature synostosis of coronal and sagittal sutures which begins in the first year of life. Once the sutures become closed, growth potential to those sutures is restricted. However, multiple sutural synostosis frequently extend to premature fusion of skull base causing midfacial hypoplasia, shallow orbit, maxillary hypoplasia and occasional upper airway obstruction. Coming to my case report, a 5-year-old male child presented with seizures to the pediatric emergency as informed by the mother. As per the history, the seizures are also associated with headache with multiple episodes of vomiting. The child was already a known case of hydrocephalus diagnosed 1 year ago and he was on VP shunt. On examination, the child's head appearance and ocular appearance was abnormal and the child was conscious but not coherent. His vitals are stable, weight is 14 kgs, height 89 centimeters, weight per age is between 2 to 3 standard deviations, height per age is less than -3 standard deviations. CVS, respiratory and GIT systems are normal. They refer the patient to ophthalmology department for abnormal ocular features. On external examination, there was frontal bossing, flat nasal bridge, micronathia, hypertelorism and canthal index was 41 and proptosis is observed. On ocular examination, visual acuity could not be assessed as patient was not coherent. And coming to the eyeball, there was a proptosis of more than 3 mm from the baseline is observed and there is a divergence of eyeball of about 30 degrees was there. Eyelids, mild legophthalmus due to proptosis is present in both eyes. Conjunctiva is normal, cornea is clear, AC is normal in depth and clear in both eyes. Iris is normal in pattern and color, pupil is round reacting, single lens is clear in both eyes. This is the image of the child. Here we can see that frontal bossing, flat nasal bridge, proptosis, mild legophthalmus and micronathia is observed. This is the B scan of the baby which is normal. On fundus examination also found to be a normal in both eyes. On CT brain it shows focal gliosis in left centrum semi-oval. VP shunt tip is present in right lateral ventricle. Unfortunately, the child has died due to the failed VP shunt. There is significant family history was also present. Consanguineous marriage history is there. Mother also had similar ocular features since birth. Here we can see that the frontal bossing, hypertelorism, proptosis, divergent squint and other anterior segment and posterior segment findings found to be normal and systemic examination was also a normal. And the younger son also had similar features since birth like frontal bossing, flat nasal bridge, micronathia, hypertelorism, proptosis, divergent squint and other anterior segment and posterior findings found to be normal and systemic examination is also normal. This is the image of the second son. Treatment we have given is just to avoid exposure keratopathy, we have given HPMC eye drops with eyelid taping. Coming to the discussion part, it is an inherited autosomal dominant pattern and is caused by mutation in the fibroblast growth factor receptor 2 and 3 which is present on chromosome 10. It has a complete penetrance but variable expressivity resulting in phenotypically unaffected to severe deformities within the same family. It is fairly rare entity and is estimated to occur in 1 in 60,000 newborns. However, it is the second most common craniosynostosis syndrome. FGFR2 and 3 are the 2,4 transmembrane protein receptors responsible for osteoblast differentiation during embryological development. Missense mutations in these 2 receptors result in gain of function, signaling and subsequent acceleration in differentiation of osteoblast. This process results in the premature fusion of sutures. In Krausen syndrome, brachycephaly is the most common presentation due to bicoronal suture fusion. Due to autosomal inheritance pattern, family history is an important component of the history. The clinical source of worsening of facial deformities over the first 2 years of life helps to make the clinical diagnosis.
Last minute.
Additional testing is usually not needed to make the diagnosis. Surgical management is the treatment modality of choice to correct the maldevelopment of midface and orbits to prevent blindness and intellectual disability related to the restriction of brain and orbital development. If the cranial vault abnormalities are corrected, patients with Krausen syndrome will have normal cognitive function, vision, hearing and lifespans. Earlier correction minimizes the cognitive disabilities, airway obstructions and decreased visual acuity. It requires long-term follow-up to monitor ocular development. These examinations should also monitor for optic nerve edema that would raise concerns for elevated intracranial pressure. Coming to the conclusion, the parents of the patient should be counseled about the child's condition and expected prognosis. They should understand that they could not have done anything before or during pregnancy to prevent the birth of a baby with this condition. The management of craniosynostosis is complex and difficult and requires a team of subspecialists including pediatricians, oral maxillofacial surgeons, plastic surgeons, neurosurgeons, ENT specialists and ophthalmologists, both pediatric ophthalmologists and oculoplastics. The nurses involved need to be specially trained to assist in recognizing the complications and educating the families. An interprofessional team approach will provide the best patient outcomes. These are my references. Thank you.
Thank you, Dr. Niharika. Very well presented, exhaustive description of the case.